this is who we are to start with. I'm based in the experimental psychology department, working as a postdoc, finished my DPhil last summer, working with Charles Vincent. Eirini used to work with me. We worked together for quite a while, and she's going to present. She's now in Greece, but she's going to present today on the project that she led that I helped with while working as a research assistant. And then Yingxi is going to talk about his work on developing a measure. This project is still ongoing, but there's a huge amount of work that's already happened there. So I will start by giving you a sort of introduction to developing, testing and validating measures, and then I'll pass over to Eirini. So Eirini's project was about developing and validating a measure of the transition of care. So this was for older people leaving hospital and going home. So you looked at the quality of their care and some of the risks in the transition, looking at the kind of safety and the quality of the transition home. And then Yingxi will talk about his work, developing and validating a measure of medical internship experience in low and middle income countries. And then at the end, I'm going to invite both projects to start to have a look at comparing and contrasting the approaches. You'll see there's a lot of things in common between the methodology, but there's also some differences which we're going to discuss. And then, of course, there'll be time for your questions. So what do we mean by measures scales in healthcare? I've got a couple of examples here on the screen. So the first one is a part of the measure that Eirini and I developed along with other colleagues. So you can see there's a range of statements here so older people would complete this over the phone. So things like, I felt I could ask staff questions about what will happen after going home. Before leaving hospital, I was confident I understood how to manage my medication, etc. So people will tick, they'll answer over the phone, and we would then fill out the questionnaire for them. This other measure I put up here relates actually to my PhD research. So this is a healthcare conflict measure. So this was all about the sort of disagreements that happen in paediatrics. So between the paediatricians or the other healthcare workers and the parents, this is really common for children with very complex needs or children on sort of palliative care pathways. So this is another short questionnaire. There's obviously lots of other measures and scales, some are considerably longer, but you can see here just a couple of examples. So why do we need validated measures? So often in health services research, what we're trying to measure is sort of subjective or conceptually very complex. So taking Eirini's example, the quality of the transition from hospital to home for older people, what does that mean? What are the different components of that? It's not something that we can sort of easily measure, like somebody's blood pressure or something. It's quite a sort of conceptually complex thing to try and start to actually think, how are we going to measure this and what are the different components going to be. So scales are typically used to capture behaviours, feelings or actions that cannot be captured easily by a single variable or item. So there's some evidence here from some randomised controlled trials in schizophrenia. And this study found that they were 40% more likely to report that treatment was effective when they used unpublished scales rather than ones with peer-reviewed evidence of validity. So it's actually quite a substantial difference when the sort of right measures weren't used. And in non-drug studies, 1/3 of the claims of treatment superiority would not have been made if the studies had used published scales. So really kind of critical to use measures that have been validated. Before I pass over to Eirini, I just want to go through why do we need to develop new measures. So whenever you start a project where you're thinking, well, actually, I might need to develop a measure, the first question, of course, is, are there any existing validated measures that you could use or modify? So there's lots of different ways of looking up the sort of libraries of measures in various different places online. For example, here, Where to Find Tests. This is part of a book. there's a sort of appendix in the book where there's a whole list of different measures. There's all sorts of different ways of searching. Obviously, you can just search literature to try and find existing measures. But the first point of call is always to look what has already been developed. So if there is an existing measure, has it been assessed with comparable groups to the to whatever you want to study in your research? If it has, then you can use it. If it's not, then you need to test it first with a sample from your population of interest to check that it is appropriate. So different measures can be validated on different populations. If there aren't any existing validated measures that are suitable, then you might need to develop a new measure. But as you'll see today, this is not a quick process. This is several years of work to do often. So if there are existing measures, always much better and easier to use existing measures. So the basic stage of developing a measure before I pass to Eirini. So the items are generated and the validity of their content is assessed. These are official steps from a well-known paper. However, from Eirini and I's project, there was a lot of work for us to conceptualize the concepts. Yingxi will talk about his scoping review later. So this phase 1 is actually quite an involved process. Phase 2, the scale is constructed. So steps in scale construction include things like pre-testing the questions, administering the survey, reducing the number of items. Often when you're developing a measure, to start with, you have many more items which are then reduced before the final measure is validated. Understanding how many factors the scale captures. So doing factor analysis on the data that you've collected to look at how many different factors you get for the population in your survey. Phase 3, the scale evaluation. So the number of dimensions is tested, reliability is tested, and validity is assessed. So this is where often you do the sort of main statistics. So I'm going to stop now and pass over to Eirini because she's going to talk through these stages in a lot more detail now for the project on the transitions of care. So over to Eirini now. Eirini, I'll just change the slides for you.
Great, thanks a lot, Bethan. Thank you, and hello from me too. Hi, Eirini. So I used to work on this project a few years ago, so it's been a while. Please bear with me if I don't remember all the details, but I do remember, and I want to reiterate what Bethan just said, that it's a long process. It's not an easy process. So if you decide to develop a measure, just make sure that it's absolutely essential because it's a lot of work. So I will now introduce to you the project that we did in 2018 and 2019. We developed and tested a measure to assess the quality of the care transition, specifically relevant to UK population. This was a 5-year project funded by NIHR. It was part of a wider project with 5 interlinked work packages, and we were one of those packages. The whole aim of the whole 5-year project was to improve safety and improve the experience of care for elderly patients as they move from hospital to home. And also another aim was to be able to reduce readmissions, so understand what are the risks involved during this transitional period and be able to reduce readmissions. Because we have seen, and the research has shown, that during the transition period, patients are particularly older patients are particularly vulnerable to risk, and they often report poor experience with their care. So a little bit on the background. So for the purpose of this project, transitions, we define transitions as the move from hospital to home, to their home of their permanent residence rather than a care facility. The transition of patients from hospital to the post-hospital setting generally is critical, especially for older patients with complex care needs. There's an increased risk for health and care problems to occur in the immediate post-discharge period, so in the first 30 days post-discharge, and this often leads to an unplanned readmission within the first 30 days. From the literature and also from interviews with patients and their caregivers, we have seen that patients and their caregivers and their family, they don't feel prepared to take on their own care at home. They struggle to understand key aspects of how to manage their condition and how to manage their symptoms. They simply don't know how to contact healthcare professionals. What services are at their disposal from their community care providers. They also feel frustrated by poor preparation for their discharge, and they struggle generally to manage their condition at home. There have been other measures that assess the quality of transition in other countries, and the closest to our construct was the CTM Coleman's measure. Was a measure that basically assesses the quality of transition. It's a very famous measure. It has been translated and validated in many countries, but the problem was that these measures and this specific measure that was closest to us, to our construct, they only focus on the immediate post-discharge period, and also they don't include any markers on patient safety that we really wanted to include. So we wanted to develop a measure to assess the experience, quality and safety of care transitions for older people at the immediate, but also long-term discharge period, specifically designed for the UK population. Right. So this is just an overview of the measure development process. I will just say a few key things about the 4 stages, and I will go into details later on. So the first stage was one of the most important ones, and it took a long time as well. It's the conceptualization of the theoretical construct. So we developed the framework of core components of the transition from hospital to home, and this framework was based on a literature review. It was based on consultations with our patient and public involvement panel. I will now refer it as a PPI panel. So the literature review, we reviewed the measure of care transitions, we reviewed interventions of care transitions. We also reviewed what other work packages of this wider project found. Other work packages, for example, identified areas that have not been explored before in this context, such as preparation of patient and family for taking on clinical tasks at home, the psychological support, feeling safe or safe at home, social factors affecting the landing back home, adverse events that people experience, other problems. So we consolidated all this feedback and this evidence, and we ended up with an 8-component conceptual model. We then moved on to the item generation. This is a process of basically designing a pool of questions and statements that represent key areas of transitions. We then conducted a Delphi process. This is an expert consensus process where experts from the PAC team, gerontologists, nurses reviewed a long list of statements that we developed and reduced it to a reasonable amount of items. We then piloted the measure with a sample of our targeted population and just made an initial assessment of its usability and face validity. The conceptual model development first. So after consolidating evidence from the literature reviews, the first literature review stages, we constructed a framework composed of 30 potential components. So 23 of those components were taken by a literature review of the measure and interventions of care transitions. 3 items were identified from findings from other work packages. They did qualitative interviews exploring the experience of older people and their families, and they highlighted key themes that are relevant to patient experience. And 4 components were identified through our discussions with our PPI panel, who talked about their experiences with healthcare. They also reviewed our research plans, and they helped us refine the measure aims in ways that could be understood basically by everyone. After removing the duplicates from 30, we ended up with 11 overarching components. 3 of those were eliminated because they were beyond the scope of the measure, and we ended up with 8 components. 3 of them were mutual to the CTM measure, the measure that I mentioned before that was closest to our construct. 5 components were not in common, so we kept those 8 as the final, our final theoretical construct. So these are the main 8 components: patient involvement, medication management, discharge arrangements, coordination with other providers, providing information and guidance to patient and family, providing psychological and social support, anticipation and preparation for emergencies or deterioration, and finally, feeling of safety. So what became clear even from the theoretical construct stage was that there are 3 important stages, 3 important time points of care during this transitions period. The first stage was in hospital preparation. So what happens in hospital to prepare people for their discharge? The second time point was early on, early days post-discharge. And the third stage would be managing care at home, longer term post-discharge. So we designed the items specifically to address the 8 components, specifically across all these 3 time points. So first, we extracted items from all the similar measures. We also included input from our PPI panel, and we generated a long list of items relevant to all the components of transitions we identified earlier. Our PPI panel also advised us that we should end up with a short, easy, kind of no more than 10-minute survey that would be easy to respond, answered with a simple response scale. So we had that in mind. After removing duplicates and after the first initial review of the list of items, we refined it to a shorter list, and then we moved on to a more formal item prioritization process in the next slide, which is the Delphi process. A Delphi process is basically an expert consensus process. It's based on rounds of discussions or rounds of surveys until consensus on a project, on a concept is reached. We use both methods. We did 2 roundtable discussions with a wider research team, and we also did 2 rounds of a web-based Delphi survey to examine content validity of the draft measure and reduce the items. The expert panel consisted of psychologists, gerontologists, healthcare researchers, social scientists, clinicians, and they rated the items on a scale based on how appropriate they thought the items were. So more appropriate items moved on to the next round, whereas less appropriate items just didn't make it to the next round. The Delphi survey looked something like the next slide. And so the pilot testing, we then moved on to the next stage, the pilot testing. We piloted the measure with a small sample of the target population. Eligibility criteria were people over 65 years old, English speaking, with at least 1 overnight stay at hospital. They also need to be discharged home rather than any other care facility, and obviously people that were cognitively able to provide informed consent. We recruited 28 participants in total from various wards, cardiothoracic, complex medical care, vascular wards, and we ended up with 15 participants for time 1, 11 participants for time 2, and 9 participants for the third time point. Generally, we found that, well, participants said that the survey was easy to respond. They didn't have any difficulties understanding. And also on the actual content of what they said, most of them were really satisfied with their discharge preparation. However, almost half of them, 50% of them, said that they were experiencing problems managing their care at home, and 20% of them said that they were not able to ask questions about their care or their medication. We also had some reports on adverse events that happened. There were issues and delays with healthcare supplies, additional care that they needed. Some people were also being readmitted unplanned, in an unplanned way, to the hospital. The final measure was a survey, a short survey that had two different versions. And it was to be delivered either by phone or by post. So the first version was to assess patient experience of preparation in hospital for their return home, and it included questions, as Bethan earlier said, such as before leaving the hospital, I knew how to manage my medication. I thought that I was able to ask staff questions about my care at home. Before leaving the hospital, I knew what arrangements had been made for my return home, things like that. And the second version, it has been designed to assess how patients are managing their care once back home. And it includes questions such as, I now feel safe at home, I know how to manage my medication, I know what arrangements have been made, I know who to contact on an emergency, or if I have any problems with my care, and these types of things. The next two slides are just an example of how the pact looks like, pact M1, and then the next slide, pact M2. And moving on to the next slide, the validation stage. So we then conduct a validation study to establish whether the measure actually measures what it was designed to assess. Next slide. So eligibility criteria were the same as in the pilot study. We recruited 185 participants in total from various wards. We tested the first version, pact M1, with 138 participants at time 1. We had 110 participants in time 2 and ended up with 92 participants in time 3. Attrition rate was between 9 and 25%, and the reasons were generally people not being able to respond to their phone. We also had a protocol. We would phone them thrice, and if they didn't respond, we would just mark them as that they have withdrawn from the study. People moved to care homes or hospice. People were unwell and they discontinued, or people just simply withdrew from the study. The mean age of the sample was 79 years old. The majority of participants were male, Caucasian, of British origin, living with their spouse or their partner. And most participants were recruited from the cardiothoracic, the vascular, and the surgical emergency wards. Moving on to the next slide, the statistical analysis. So if you want to validate a measure, you first need to look at these first markers of validity. So the analysis generally showed that both measures, both versions of the measure, had good reliability values. I think anything about 0.8 is very good reliability or excellent reliability, something like that. They had good inter-item correlations because they were ranging between the optimal recommendations between 0.2 and 0.6. And the factor analysis revealed a single factor solution for both versions. So we had a single factor for pact M1 and pact M2 with good factor loadings for all items. So a few things about the factor analysis. So when you develop a measure, you want to do first an exploratory factor analysis, which is a data reduction technique. You want to identify the latent factors. You want to see how the items are being grouped. It's a data-driven procedure, and it wants to explore the underlying structure of the data. The conundrum with our first with the first version on the next slide was that if you look at the scree plot, so a scree plot always is a downward curve, and the point when the slope of the curve is clearly leveling off the elbow indicates the number of factors that should be generated by the analysis, the number of factors that are sufficient to describe the essence of the data. So this scree plot wasn't entirely clear whether it has 1 or 2 points, so whether it was 1 or 2 factors. So we had to look at the component matrix, and as you can see, there are some items that they also cross-load on the second factor as well. Most of the items that load on the second factor we didn't really take into account because they have stronger loadings on the first factor, so this seems that they are the better fit. They're better fit for the first factor, but item number 2 was a little bit of a problem because this item had a stronger loading on the second factor rather than the first factor. So we thought a lot about how to proceed with this result. We had to go back to the theoretical construct and remember what item to represent. Excuse me. Because we designed the pact so that all of the items basically represent one of the 8 factors, one of the 8 components that we identified through the conceptualization process. So we had to go back and remind ourselves what item 2 represents. Would it be okay to have a 2-factor solution? We finally decided that it makes more sense to keep the single-factor solution, and just mentioned as a limitation that this specific item has just a lower factor loading on the first factor, on the single factor. On the next slide, here it's much clearer that for the second version, for pact M2, there was no cross loadings. The scree plot is clearer. It's a steep line that is leveling off clearly. So no issues with that, no problems with that. So after all this procedure, on the next slide, is the measure valid? To establish the measure validity, we followed Cook's validation guidelines that go beyond the older concepts of phase, content, and criterion validity. And Cook replaces these old concepts with the term construct validity. So the degree to which a score is representing the intended underlying construct. So our evidence to support the validity, each validity criteria was collected by various sources. So the first criterion was content. So do the instrument items completely represent the construct? We established that by doing the literature review and the Delphi process. The second is the response process. So this criterion has to do with the relationship between the intended construct and the thought process of the response of the subjects of the target population. We established that through the pilot testing and through the PPI advisory groups. The third criterion, internal structure, this has to do with acceptable reliability and factor structure. So we established that through factor analysis, inter-item reliability, internal consistency, etc. And the next 2 criteria would be established through the pact intervention. So the fourth, relations to other variables, this has to do with the correlation with scores from the instrument, assessing the same construct. And the final one, the consequences, which has to do with whether the measure actually makes a difference to the target population. Does it make any sense using the measure or the scale, basically? This, again, was to be determined by the pact intervention at a later stage. To conclude, The ACTEM was the first to evaluate care transition quality and safety for UK population. It highlighted areas that other measures overlooked before, such as patient safety, patient involvement, multiple areas of transition, multiple times of transition. It can reflect on patients' ability to manage their care at home, early days post-discharge and further down their care journey, and can be used by people that are being involved in implementing, planning, evaluating discharge care and for interventions. And it's currently in the process of being translated and validated in China, Turkey, in Japan and USA. So that was all for me. Thank you. And now Yingxi will tell you everything about his work.
Hi everyone, I'm Yingxi Zhao. I'm currently a third year DPhil student and presenting one component of my DPhil project, which is still undergoing. So unfortunately, I couldn't provide you with the final scale item I've developed. It is looking at the internship experience of medical doctors in low and middle income countries. So the first question is like, why do we need to care about medical interns? So there are definitely multiple reasons. Thinking about the workforce health and well-being, medical internship is a very stressful period, transitioning from supervised learning in medical schools to actually assuming rapidly a significant clinical responsibility, usually under supervision. And this will include very highly demanding working hours, really not well paid, sometimes limited supervision and fee provided. The front line of patient management, and this will all threaten the workforce well-being and well as the quality of healthcare being delivered. And the other important aspect to consider is to recruit and retaining the health workforce. Usually, internship is a critical after they finish their internship and usually after their license. They may think about choosing a specialty or sometimes migrating to another country, which is quite common for many low and middle income countries, causing the brain drain problem and also very huge economic loss to the country who provided the training. So thinking about the experience of medical internship or even more broadly on junior doctor training, the US and the UK have actually conducted similar surveys. Oops, nope, I just jumped too much. Have conducted annual trainee surveys in the UK and the US, but not so much in low and middle income countries. So the UK, the General Medical Council, have an annual trainee survey that recently, I think 4 years ago, have included a burnout inventory under their survey. They covered quite a broad list of different aspects of their training, their education, their relationship with their co-workers. And in comparison, in the US, the ACGME also have a resident / fellow survey that cover around 8 different components, including their well-being, their work hours, their perception of their education. So those are two good tools. However, following up what Bethan previously had mentioned, are they actually applicable to low and middle income countries setting? So we did a very brief look at the question they are asked. So the GME survey is actually quite specific to the UK condition. There are many questions that are very hard to be adapted to low and middle income country. And also more broadly, there are some other aspects that we need a little bit more consideration when designing or understanding the experience of internship for low and middle income country. For example, the perception of their patient safety, as well as the more infrastructure and resource availability in hospital, which are sometimes usually quite lacking in those settings. So we first did a scoping review to understand what we actually mean by internship experience. The review has already been published. I think the reference is provided at the end of the slides. So we look into literature and just searching what actually people are measuring quantitatively for internship experience. So we end up with 92 papers, and we summarize what are the major concepts they have been looking into. We decided on there are 3 major themes that were emerging from the literature, including their well-being, their perception for the educational environment, as well as their perception towards the work condition and environment. So we also, through this process, we have come up with a list of different kind of tools that are useful to understand those 3 major themes. So for well-being, there are people measuring stress using the perceived stress scale more oftenly, using patient health questionnaire 9 to understand depression, as well as there's a very good tool called postgraduate hospital educational environment measure, which is developed in the UK to understand teaching and supervision, organizational support, some components of work condition. But as I said, we want something a little bit more considering the condition in low and middle income countries. So we also want something a little bit more on safety culture, on physical resources. So that's why we want to actually develop a new scale instead of using the previous ones or using the one that are listed on the list here on the screen. So the idea is we want to develop a standardized questionnaire, i.e. a scale or instrument to understand what is the internship experience in low and middle income countries, so that with this good scale developed, we can use in one single country to assess across different time to understand what the trend of internship experience. Did the internship experience improve over time, or did it actually were going really badly in the following years? It could also be used within a single country to understand what is the regional difference or disparity in terms of internship training experience. Did people working in certain capital city have a better experience, or do they have worse experience? And even more broadly, to use across different countries to allow comparison to see which country are doing a little bit better or which country are doing a little bit worse. Right, so our scale development and validation activities conducted, we have selected a few collaborators from 10 different low and middle income countries, and hoping they can help us throughout the process in terms of validating the scale, understanding whether they are applicable to the local context, and also sending in a questionnaire to collect enough response for us to do a more global analysis to make sure the scale is working across different countries. We're also hoping to conduct a global survey covering countries outside of the one we have highlighted. As you have noticed, we haven't had any collaborator from South American, and also we're quite limited in terms of the low and middle income country we have covered. So we want to use another global survey to add up the response a bit as well. So the development of the scale process is similar to what previously Bethan has presented. We also have 3 different phases, including developing the item and then developing the scale, and lastly, evaluating the scale. So I'm currently halfway through the second phase, so I'll introduce what I've achieved so far and also what my hope is going forward. So the first phase in terms of item development, the first step is to identify the domain and generate the item to select which item we are asking. So we are using the result from the scoping review to generate what are different domains that we are measuring. So we have 10 proposed domains following the scoping review results. And also the question, we actually adapted some of the existing tools instead of really developing from scratch. So we are using existing tools and quite heavily adapting them, and sometimes even destroying some of the original scales to make sure it fit our proposed idea or proposed concept of internship experience. So some of the destroy I've done, including just completely rewording them or completely destroying the response scale from a 1 to 4 point Likert scale to 1 to 5 point, and sometimes deleting the items that we felt are not relevant to the local setting. So after the first step, we have ended up with 102 questions, and all of them are standardized to a 1.5 Likert scale response. And the second step is to assess the content validity to understand whether the items actually adequately measure the domain of interest. So we've done it through 2 different steps. The first one is we conducted participant content validity workshop. So for each country, we have organized a kind of focus group discussion with interns in those countries and just showing them the questionnaire, asking them if the items for them looks relevant. Is there anything else that we haven't captured in the item that needs to be added? Or is there any item that I felt are not relevant that we should be deleted or should be reworded? So we have conducted it in 7 different countries with a total of 43 interns. And after this step, we moved on to the second step of conducting an expert panel with 14 different experts, people from either they are consultants in low and middle income countries who are familiar with the training of medical interns, or there are some more people from psychiatry and who understand a bit more on the psychometric scale development process. And after this step, we're asking them to identify what are the indicators that are the most relevant to understanding internship experience. Bearing in mind, we have 102 questions, which is quite a long questionnaire, and we are trying to shorten the questions that are not so relevant to internship experience. We're asking them to rate each question by 1 to 4, 1 meaning these are not relevant and should be deleted, and 4 are highly relevant and don't need to be revised at all. And the overall contentability index for all the 102 items are 0.86, which is quite good. But also we have noticed there are 14 items that have a CVI below 0.78, which is recommended to be deleted in this step. So that's why we have deleted those 14 items, leaving 88 questions after this phase. So we haven't done a Delphi panel due to time and resource limitation, but we have done the expert panel using a quite simple approach of contentability index. And moving on to phase 2, which is the scale development process, we first started pilot testing the questionnaire, ensuring all the questions and answers are meaningful. And similar with the previous example, we also did a cognitive interview with 15 interns individually using 2 approaches, i.e. the think aloud approach and probing approach. So the key step of this in comparison with contentability is to actually make sure the sentence themselves and the items themselves are understood in a similar way that we intended. So we will ask the respondent or the cognitive interview participant to verbalize the mental process entailed in providing such answer to make sure that they really understand the question, they really understand each wording. So for example, there'll be questions, there'll be item on, I received enough supervision during my internship training, and I'll ask them like, what do you think, like when you read this sentence, what we're thinking in your mind, what are the supervision activities we're thinking about? So this step is actually very important in our development process, as we have found out a few items are not understood correctly due to some of the wording being not so commonly used in English. For example, there's one item called I feel evaporated after my internship, which is adapted from one of the previous scale. And we've later find out a lot of the interns actually couldn't understand what evaporated means. So that's why we have to actually change the wording to a simpler version. So this is a pre-testing questionnaire. I think also this is very important when you are translating the scale from one language to another one. In our development process, we have translated this into French, Vietnamese, and Chinese, and pre-testing them in the local language is also very important to make sure the translated version have carried a similar meaning with the original English version. And afterwards, the 4th step is to send out a survey. And also one key consideration in this step is the sample size. How much sample do you need? In our development process, we conduct this survey both online through RedCap and Microsoft Forms in some countries. We also use a paper-based questionnaire. And our study inclusion criteria for the study population is current interns who recently finished their internship or people who finish it within 3 years of time. We don't want it to be too long, as there might be a bit of recall bias. So we have set a limit to 3 years for most countries. In terms of how much sample do you need for the scale development process, I think people will know there's no set limit. There's no number that you definitely have to achieve. And very likely it's more depending on how many resources and how many time you have. So I've digged to a few of the literature, and there are 2 criteria that people usually use. So for a scale development process on its own, usually you have a rule of 1 item to 10 participants. So if you have 20 questions in your scale, then usually you will need at least 200 participants. In our case, I have nearly 100 scale items. So I need about 1,000 participants in total. On the other side of it, for factor analysis, which has been introduced previously, but also I'll talk a bit more about it in later slides. For factor analysis itself, usually if you have 10 or more items representing each domain or each construct, then usually a sample of 150 response will be sufficient enough to achieve a quite good resolution for factor analysis. So combining those 2 criteria in mind, like our criteria or our hope is to achieve at least 150 response per country, and ideally achieving about 1,000 total response for the global survey, as well as combining all the 10 different countries sample size. But again, those are not strict rule. It will largely depending on how many time and resource you have. Yeah, and moving down to the latest step of scale development, which I've only started looking into a few samples from Kenya, so I really couldn't provide all the results here. The fifth step is item reduction to ensure that all the items are functional. Usually, if you use item difficulty index, inter-item correlation, inter-total correlation, so to find out what are the items that are not so correlated with other items in your total scale, which means that probably they're not measuring the same thing that you're hoping for, or they're not measuring it properly. And to the sixth step is the factor analysis. Usually at this step is a exploratory factor analysis to understand what are the latent structure that you will be looking into. In my analysis, I'm likely going to use half my sample for this step. There's two different ways of doing factor analysis in terms of rotation, the orthogonal and oblique. The difference between those two are if you think your domains or your construct are correlated with each other, then you should use oblique rotation. If not, or if you're hoping they're not correlated with each other, then you should use the orthogonal. And then the scree plot, as Eirini has previously presented, is a good way to understand how many factors are out there, and for you to decide on which step, how many factors you extracted. And the last step or last phase is the scale evaluation, which I haven't started at all. We usually have to think about tests of dimensionality to understand whether the latent construct are as you hypothesized. Sometimes we use another half of the sample to do a confirmatory factor analysis to make sure that it really comes out as same. Or in my case, I'm also thinking of using a multi-group confirmatory factor analysis to see whether the scale perform exactly the same in a different country in 10 of the countries that I've selected. But the point for the multi-group confirmatory factor analysis is you have to have a sufficient sample size for each subgroup. So for countries, if they only have 20 responses, it's very likely the confirmatory factor analysis won't perform as good, so less reliable. And the last two steps are the tests of reliability and validity. We use the alpha as well as the Crookes criteria, which has previously been presented. The key information I provided here and also previously has been presented by Eirini. I think that's all of my slides here. Yep, back to you, Bethan.
Great, thanks for that, Yingxi. I'm just going to step back now. So to finish, before we invite you to ask some questions, we just wanted to reflect on some of the key differences. Let me get my camera back on. So you've heard from two projects. Eirini's is completed now, Yingxi's is sort of over halfway, but still ongoing. There's a few things that I've picked out that I guess are sort of similar or different. So Yingxi's study began with a scoping review, and he identified that there were various sort of useful existing scales for certain components like measures of burnout, teaching and supervision. So possible to use some of these items and scales as part of the measure. Whereas PACT-M, there were sort of few existing measures. There was the Coleman measure, that captured some of the components that were important. But the PPI group for the PACT-M development was really critical. So that kind of conceptualizing work began with a sort of literature search, but it also involved a lot of work with PPI and clinicians to try and get that. So what were the main components? So that conceptualization work, there's the first paper, which I'll show on the references shortly. But that was actually quite, a long piece of work just to get that right before you could start sort of generating items and testing the measure. Differences in the structure and the content of the measure. So as you could see when PACT-M was put up, it's much shorter. So you imagine when we're actually running this survey with older people, we were ringing up quite elderly people with hearing problems, sometimes with sort of some level of cognitive difficulties. I mean, one of the biggest problems, I think, was the hearing problems. That certainly be my experience from ringing up some of these older people. But it did really need to be a short measure, and that was sort of critical to the sort of feasibility of it. And there were 3 different time points to the packed measure. So while just after people have come home from hospital, and then at 2 later time points. So when we look at Yingxi's measure, it's much longer. So around sort of 100 items or so. I don't know exactly how many will be on the final measure, but they're quite different practical constraints. And Yingxi, as he's talked, was mentioning, can we get this measure to work in lots of different low and middle income countries? So there's a lot of work that goes on to thinking what population will this measure work in. So, for example, the packed measure has since been translated in a few other languages that Eirini mentioned now. So what I want to do now is invite Yingxi and Eirini back just to add to this and mention some of your own reflections on what's kind of different about the 2 measures, and then we'll bring in everyone in the audience to ask some questions. So if we start with Yingxi, if you've got anything to add here on the differences.
Thank you. I think you have covered most of it. I think the other consideration that I haven't really thought of previously, but thought of just now is quite linked with survey design, like how your survey or scale is delivered, whether it's through a telephone in your in Eirini's example, or in my case, sometimes more likely through an online database or a paper-based design that will actually lead to many different practical constraints, and also how the questionnaire will be designed, like how long the question could be, what are different like scale items, how they should be delivered, whether you should talk to them previously, asking them to rate it from 1 to 5, or when it's still through an online web page or through a phone that people can actually look at it, and being reminded constantly this is a negative weighted one, to make sure that people are following the questionnaire like quite carefully. So I think it's very much linked with how the tools are delivered. And there's tons of books on survey design, different ways of survey design that I think people should also think about when developing a scale item.
Great, thanks, Yingxi. Eirini, have you got any reflections to add on the differences or similarities?
Yes, exactly. Thanks, Bethan. Yes, and I agree with Yingxi, and also I think most of the differences have been covered. Yeah, one thing that I noticed is that all the complexity, basically, and all the nuances that need to be considered when having a measure that has to work in all those different countries, different cultures, different languages, and like basically the complexity of having a measure to work, the same measure to work in these different contexts, in these different healthcare systems, whereas in our measure we developed it for UK population, and it was then validated and used elsewhere, whereas Yingxi has to do that from the beginning, which is a very complex and very interesting procedure. So yeah, that would be my main reflection. That.
Great. Well, I'm just going to share a few references here, and then I'll stop sharing the slides so we can invite people for questions. On this slide here, we've got some references that between us we've sort of compiled as useful in terms of methodology. So there's some sort of introductory, either papers or books, or some that go into a lot more detail. There's, for example, the Cook's validity criteria that both Eirini and Yingxi talked about. There's a link to the paper there. So there's a book here, I think, on internet, phone, mail and mixed mode surveys. So that's come up in our discussions a bit. So there's loads of reading out there, but these are just a few papers that we would recommend. And on this last slide, we've just got the papers from these 2 projects so far. So you can see both of Eirini's papers there, on the first stage on sort of conceptualization, and the second on the validation with the 100, and can't remember how many people we had in the sample in the end, but over 100. and then Yingxi's scoping review, and I'm sure there will be more papers due in the next year or two from Yingxi's project, so do keep an eye out for these papers when they come out.